Thank you, Terry, and thank you, organizers, for inviting me. It's truly an honor to be here with you and to be the last presenter to help wrap up what's been an amazing lecture series this weekend. So as Terry mentioned, the title of my talk today is Nutrition-Based Labs That Every GI Should Be Considering. And the title of this lecture and the topic of this lecture really comes from my own personal interest, which was something that unfortunately was not talked about in graduate school the way that I would have hoped or expected it to have been. So over the past 4.5 years of working at UCLA and being a dietitian, I've done a lot of looking into the research, talking with the GI doctors at UCLA, as well as forming groups with GI dietitians across the country to try and come up with what are best protocols and what does the research say about the types of nutrition-based labs we should be running with our patients. So what you're going to see is what I've come up with so far. So as an overview, we're going to do a very quick review of the vitamin and mineral basics. It may have been a little while since you looked at these. And then we're going to go into the mind of a GI dietitian. And we're going to talk about some GI nutrition considerations, so the types of things that I'm thinking about when I have one of our GI patients sitting with me in clinic. And then we're going to actually put it into practice by looking at 3 different disease states: celiac disease, inflammatory bowel disease, and GERD. For our vitamin and mineral basics review, just as a reminder, our vitamins are divided into 2 broad categories: water soluble, which means that they are absorbed through the portal blood system. And then we've got our 8B vitamins and vitamin C. And then we've got our fat soluble vitamins, which have to move through the lymphatic system. And this is A, D, E, and K. Our minerals are divided into 2 broad categories as well, and this is based on the amount of them that we need per day. So for our macro minerals, we need about 100 milligrams per day or more. With our micro, we need less than 100 milligrams. So clearly this is not based on their importance or functionality in the body. It really just has to do with the amount we need. And this is one of my favorite charts that I ever saw when I was in graduate school, and I would have loved if they had spent like a whole semester on this, and instead we spent about 2 minutes. But this has become a chart that I put on my wall, and I will review with the fellows when I'm working with them. It reminds me of 2 things. One thing is that when we're talking about the digestive tract in terms of nutrition, we are thinking about, one continuous connected system, but we really have to be thinking about how each of these component parts is utilized in terms of absorption and digestion when it comes to the different diseases that we see. So what does that mean in terms of what a GI dietitian is thinking about? So when I have a patient come into clinic and work with me, of course, the first thing I'm going to consider is what diagnosis they were given by the doctor. And once we have that information, this is usually kind of a stepwise approach that I will take with the patients. So I start by thinking about the anatomy. Not only what parts do we generally think of as being affected by the different disease diagnosis that they've been given, but also what have we learned from different procedural results, and then of course if there's been any resections or surgeries that have taken place, if any of the anatomy has been removed or changed in any way. And then, of course, we want to think about the disease activity status. So whether they're in remission, symptomatic, whether disease is active, and really looking at procedural results for this as well as blood work results to get this information. And then finally, what do we do in terms of their diet? So I always like to point out that there's a difference between what the patient is currently eating, what is considered an appropriate diet, and then what is considered dietary adequacy or an adequate diet. So when we think of an appropriate diet, we're thinking about what diet would be appropriate for the disease that they have and for management of that disease. Adequacy goes a step further and says we want to make sure that they're getting all of their nutritional needs met as well. And in my mind, the nutrition prescription really needs to include one more element. So we we want to make the nutrition prescription the least restricted diet we possibly can to achieve symptom control and disease management, and this is the important part, but maintain quality of life. Because eating is a pleasure, and it's something that we want to keep as pleasurable for our patients. And this may mean that we have to look at supplementation, especially if changing the diet too much would decrease their quality of life, or if they've got significant deficiencies in which supplementation would be appropriate. So let's put this into practice. And we're going to start with celiac disease. So going again from that GI nutrition consideration chart that I just showed you, you heard a great talk from Dr. Weiss earlier about the anatomy involved with celiac disease, and really what's important here is looking at the disease activity status. So if the patient is a newly diagnosed celiac patient, we may want to run different labs than if they are clinically in remission. Maybe we won't. We're going to talk about that in a second. Also, if they're non-responsive, or what we call our non-responsive celiac patients, these are often patients who are not compliant with the diet, and this is when we really have to dig into whether or not they are following the gluten-free diet adequately. And again, in terms of quality of life, calling it a gluten-free lifestyle can be very helpful for helping these patients understand that yes, it will involve many aspects of their life, from grocery shopping to dining out to eating with friends and family. And as Dr. Weiss had mentioned, we usually talk about classic versus non-classic celiac disease, or what used to be termed as typical versus atypical. And we were really looking at malabsorption as kind of the key component of that. But there's a lot of different types of signs and symptoms that we will see with our patients that really have to do with the different types of deficiencies that are coming from nutritional malnutrition, right? So we see malnutrition because of the malabsorptive processes that are happening with celiac disease. And this can include anything from memory loss to sore or weak muscles, dental issues, brittle nails, neuropathy, or even balance issues. So luckily, we have some interesting research to look at when it comes to what type of nutritional labs we should be looking at for our newly diagnosed celiac patients. So this was a research project that came out of Beth Israel Deaconess Medical Center, and a good friend and colleague of mine, Melinda Dennis, who's the dietitian for their celiac center there. And she was looking at their patient population and running these labs to see what percentage of these patients were showing up with deficiencies at the time of diagnosis. And you can see it's pretty amazing. We see iron up to 50% in our patients at the time of diagnosis, B12 41%, folate up to 42%, and this is one that's often overlooked by our doctors, zinc. So 54 to 67%, that's at least half of your celiac patients at the time of diagnosis are going to have zinc deficiency. So this is really one to be considering and looking at. The problem is that post-diagnosis, we're seeing a lot of the same deficiencies in our celiac population. And unfortunately, this isn't an inherent lack of nutrition in the gluten-free diet itself. It's a lack of nutrition in our food products that have been made. And with the advent of the whole gluten-free trend, there's been an upsurge in these gluten-free products, everything from breads and cupcakes and donuts and pretzels and crackers. But unfortunately, none of these products, or very few of these products, are actually enriched, which means that all of that good nutrition that was originally in the gluten-free grains before they were processed is pulled out and not added back in after diagnosis. And you'll notice that in red, a lot of the same deficiencies we were worried about at the time of diagnosis tend to be present even post-diagnosis when a patient is on the gluten-free diet. And you can see I've highlighted, so the labels on the screen are for roughly the same volume of pretzels. The gluten-free version is on your left-hand side, and the gluten-containing is on your right-hand side. And you can see in that red box that I highlighted for you the enrichment process. So you can see that iron, riboflavin, thiamine, niacin have been added back in to the gluten-containing pretzels, whereas this same thing is not happening with our gluten-free pretzels. So you're going to see several slides that look like this throughout my presentation. I'm not going to spend a lot of time on each one of them. This was more for you to have after. When you go back to your clinics and you're working with these patients and you're considering what types of labs to maybe consider for these patients we're going to be discussing today, I'm hopeful that these charts will be useful to you. I'm also going to be giving you charts on possible ways that you can replete these patients. And of course, with our celiac patients, anytime you're going to recommend oral supplementation, you need to make sure you're telling them to take a gluten-free supplement. It sounds kind of silly, but a lot of patients will not remember that anything that goes in their nose or their mouth needs to be labeled gluten-free, or that needs to be clear to them that it's gluten-free, which they learn to do by label reading with a skilled dietitian. And then a lot of these celiac patients get lost to follow-up, and I can tell you as a celiac patient myself, it's really important that we have a good relationship with our gastroenterologist. It means a lot, I know for me, to be followed up every year by my GI, to have celiac antibodies tested every year, thyroid done every 2 years until, if hypothyroidism is found, which you saw is up to 20% of our celiac patients. And then a DEXA scan is something definitely to consider, because we know that early onset osteoporosis can be an issue in non-compliant or not before diagnosis for these celiac patients. So we want to check it after there's been normalization of the antibodies or at 1 year. And then, of course, anytime there was a nutrient deficiency, my recommendation is check after supplementation has been started at 3 months, 6 months until replete, and then on an annual basis until you're convinced that the patient is fully repleted. So what about inflammatory bowel disease? So again, going back to our GI nutrition considerations, with ulcerative colitis, we're talking about the large intestine. With Crohn's disease, 40% of our patients are going to be ileocolonic, and about 20% will be colon only, so most of our patients are going to be the terminal ileum and large intestine that we're focusing on. And with the disease activity status, this becomes really important, whether they are clinically in remission, if they're in a flare, or of course with our Crohn's patients, up to 75% of them are going to have surgery at least once in their lifetime. We want to be thinking about what does the remaining anatomy look like, and what parts of the anatomy have been resected that we may want to be considering for possible deficiencies. With dietary adequacy, unfortunately, a fair number of these patients follow restricted eating patterns based on fear of having symptoms, or based on blog sites that they've gone to, that they've read they should be following some diet, usually a fad diet that worked for one person but has not been shown in studies to be effective for the general population. And actually, there was a study done in 2013 that showed that 2/3 of our IBD patients are going to be on some sort of restricted eating behavior because of fear of causing a flare. So it is something we need to be paying attention to in this patient population. So what types of deficiencies do we need to be worried about? So as I mentioned, malnutrition is a big one, whether it's because of increased disease activity, which the prevalence of malnutrition goes way up when patients are actively in a flare state, but again, just from poor dietary choices can cause decreasing calories, as well as when these patients are in a flare, they're in a catabolic state. They're burning through their protein stores, so protein energy malnutrition is another one that we should be keeping an eye out for. Iron deficiency anemia, about 57% in our IBD patients. Again, this goes up when we have patients who are malnourished, when they're in a flare. But you'll notice that we also have to be concerned about B12 and folate deficiency in these patients, because the total anemia is about 88% in this patient population, to the point where ECHO actually came out with guidelines on testing for B12 and folate on a consistent basis, even in patients who don't show for macrocytosis. So in terms of B12 and should say folate, about up to 48% of our patients will be B12 deficient, up to as high as 54% folate deficient. And then there's actually been a lot of really interesting research coming out about vitamin D and our IBD patients. All of it is correlative, none of it is causality at this point in time, but what we're seeing is that there's an inverse relationship. When the vitamin D levels in the blood look good, we see changes for the positive and quality of life, and in terms of disease course, it seems to be lessened, as well as morbidity. So it seems like a pretty easy thing that we can do for our patients is run a vitamin D level and supplement up to appropriate levels for them just to keep them within range. With vitamin A and magnesium, these tend to go down during acute phase, mainly because of the diarrhea and the loss of these in the bowel movements. And again, zinc, we're seeing it again in another of our GI diseases. Up to 70% of our Crohn's patients will have some form of zinc deficiency. So zinc is another one that we really should be keeping an eye on. So here's one of those lab charts that I promised you. And I just wanted to point out that I added into the vitamin B12 area an MMA and a homocysteine. I'm still a fan of running a serum B12 first. It's got about a 12% false negative rate. So when you're really suspicious that your patient has B12 deficiency, especially if the terminal ileum has been compromised because of a resection or active disease state, and MMA and homocysteine are more sensitive predictors of B12 deficiency, and it may be worth doing. And as I mentioned, the ECHO guidelines do say that all IBD patients should have their serum B12 levels and a folate, it should be an RBC folate, measured annually despite symptoms. And here's some of my suggestions for repletion. Another of the ECHO guidelines that I just wanted to point out is they actually recommend foregoing oral iron supplementation and instead going straight to IV infusion. The reason for this was because the amount that you would be giving these patients, which is the usual 325 milligrams, ferrous sulfate times 3 a day, is more likely to cause GI distress in these patients. And in order to kind of mitigate that, they recommend an IV infusion. And for magnesium, we're always worried about magnesium having a laxative effect, and especially on a patient population that is already having lots of loose bowel movements. A way that we can go around this is to start with low dose levels and to choose versions like glycinate over versions like oxide or citrate, which have a better absorption rate and are less likely to contribute to diarrhea in this patient population. So finally, gastroesophageal reflux disease. You heard a wonderful presentation by Kevin Gassemi earlier today. So I'm going to be reiterating some of the points he already made, but I also wanted to bring your attention to a couple other nutritional values that maybe we should be considering. So again, with the anatomy, we're all familiar with the anatomy with GERD. Really what we're most concerned about are the deficiencies with these medications, because my guess is your patients are constantly asking questions about this. So let's just talk a little bit about the metabolism of some of these different nutrients that there's concern about. So with magnesium, as Kevin had mentioned earlier, we're worried about the active transport channels with PPIs, but again, the mechanism is unclear at this point in time. And really just having a good knowledge base of the different types of signs and symptoms we might see from our patients. The most common one we see are muscle spasms, muscle cramps, muscle weakness, fatigue, but unfortunately that can be a lot of different nutritional deficiencies. So what do we see from the research? So the research shows us that deficiencies in magnesium can happen as quickly as 6 months. And unfortunately, there isn't really a typical patient profile for who we think is at higher risk for having a decrease in magnesium levels due to PPI. Although the FDA did come out with a report in 2011 where they said that renal wasting, those on loop diuretics, intestinal malabsorption patients, potentially at higher risk. There was one study that showed there's possibly an increased risk just in the general population, where they took a 40 milligram dose PPI, gave it to healthy volunteers, and saw a reduction in magnesium absorption by 1% in a week, and they did statistical analysis and predicted this could be as much as 80% in a year. Whether that means we should be looking at it in our general population, there isn't any recommendation at this point in time, and I'll give you my recommendations once I go through all of the different nutrients. With B12, we need the gastric acid to help release the B12 from the protein-bound structure that it's found in food. This is then allowed to connect with intrinsic factor, where it is brought to the terminal ileum for absorption. But something to keep in mind with B12 is that deficiency rates go up as we age. So the NHANES study showed that in the elderly population, so 65 and above, that 3.2% of them had seriously low B12 levels, and that up to 20% of them were considered to have borderline deficiencies. So this is even without PPI use, this is just this patient population. We know that a lot of our reflux patients do happen to be above 50 years old. Another thing to keep in mind with B12 is that it's a slow developing disorder. We have the ability to store a fair amount of B12 actually in our liver. We can store up to 2 years worth. So really, if we are going to see deficiencies related to PPIs, it wouldn't be for at least 2 years. And again, some of the different signs and symptoms to be looking for, the most common ones I see in clinic are peripheral neuropathies, as well as memory loss or reasoning ability changes. And so what does the research show us about the risk with B12 deficiency and PPI? So again, we see that it doesn't start for at least 2 years, and this is when patients are on 1.5 PPIs per day or combined therapy of the PPI and H2 blocker. But again, the research was really inconsistent. It struggled to figure out the right patient population to be checking for, as well as average doses. And again, a lot of these studies didn't control for diet. So if patients were on a vegan or a vegetarian diet, that was not looked at in these different studies as far as I'm aware. And finally, iron metabolism. So gastric pH below 3 will help to release ferric ions to their much more absorbable form, which is the ferrous. Heme type of iron is independent of the gastric pH, whereas our non-heme iron actually requires this gastric pH. And unfortunately, you can see 70 to 90% of the Western diet is made up of this non-heme form. And that might be surprising to some of you who thought that when you eat animal proteins, you're getting all heme form. Actually, 60% of the iron found in animal proteins is of the non-heme variety, only 40% is of the heme variety. So it still can be an issue even in our carnivores. And the symptoms we're all very familiar with, things like weakness, fatigue, patients describing not being able to walk up a flight of stairs without getting winded. If it's really severe, they may have pica or the desire to eat non-food items, usually ice chips. So what does the research show us in terms of deficiencies? So it looks like PPIUs can prevent the non-heme iron absorption, possibly as much as 52% decrease. But what I thought was really interesting is in every study I looked at, they were looking at hemoglobin, hematocrit, and MCV. These are once the iron stores have been completely exhausted. They weren't looking at things like serum iron and ferritin levels, which are an earlier marker for more mild or marginal deficiencies. So it would have been curious on a timeline how long these took, and I didn't get a good understanding of that from the research. But one study that was a few cases showed that low serum iron and ferritin levels started anywhere between 6 months and 4 years. So not a very helpful measure for us, unfortunately. So what are my current recommendations? The FDA gave us this guideline in 2011 that recommended checking magnesium at baseline when you first give a PPI, and then they say periodically afterwards. They don't describe what that periodic looks like. It would be reasonable at every 6-month interval, and especially they say to do this with our at-risk groups, which they label as renal, wasting, loop diuretics, intestinal malabsorption, and they actually say long-term PPI use, which is anywhere from 1 to 2 years. With B12, again, it's probably higher likelihood in our elderly population anyways. So if you are highly suspicious based on the age of the patient in front of you, the dietary composition of what they're currently eating, as well as long-term PPI use more than 2 years, a serum B12, possibly an MMA homocysteine, if really suspicious, might be warranted. And then I did not choose to talk about calcium in my talk today because you heard from Dr. Gassemi earlier that it's so controversial and that there's so many confounding factors that go along with why patients have osteoporosis that it might be something, at least for me, I don't touch it with my patients, but a DEXA scan per a primary care physician, especially in our patients who are above 50, might make sense simply because they're at higher risk for osteoporosis, especially our white, Asian, and female patient population. And then, of course, what should we be thinking about in terms of repletion? So hopefully this will be a chart that's useful to you in the future. And I feel like as a dietitian, I'd be really remiss in not putting at least a pretty image of food up on the screen at some point in time. So this is my reminder that it's always great if we can start with food. So supplements are wonderful. It's nice that we have them as an option. But anytime we can start by giving our patients food sources, again, of course, if the deficiency is really severe, we're not going to do that. But in patients where it's a mild or moderate issue, these are some of the food sources that maybe we can consider. And these actually come from the NIH. They create these dietary supplement fact sheets that you can actually print off for your patients. And they update them every year. So this is their most updated list from 2016 of just some of the foods. And you'll notice that if patients are eating a well-balanced diet with nuts, seeds, legumes, good vegetables and fruits, as well as possibly dairy products and animal proteins, they're less likely to have these issues. So the take-home message is, if you choose to run some nutrition-based labs and you feel like thinking like a GI dietitian, here are the steps that I walk through, thinking about the anatomy involved, the disease status in terms of activity, and of course, the dietary adequacy. And since we talked a lot about repletion, but I didn't actually talk about supplements today, just to give you a little bit on supplements and what to look for, of course, we always want to base the amount on what the labs have shown and what the diet currently looks like. You can always look for GMP or NSF labels. These are third parties who go into these supplement manufacturers, and they're checking to make sure that what they say is in their supplement is actually in their supplement, and what they say is not in their supplement is not in their supplement. So it's a way of having just a little bit more safeguard that you're giving your patient a good supplement to take. And then, of course, once you've started supplementation, rechecking labs at 3 and 6 months, and then annually as needed, just to make sure that the patient is replete. And I have to do a shameless plug, which is this is where our GI digestive health and nutrition program is heading. It's been really wonderful growing this program where we started with just nutritional guidance, and we're now starting to bring in stress reduction therapies. So for our functional gut patients, we can do mindfulness-based stress reduction techniques and abdominal breathing work. We're also doing integrative therapies, essential oils, and Reiki work. And then, of course, we're starting to do research, which, as Terry mentioned, is going to be actually starting this month. So I thank you for your attention, and congratulations on getting almost to the end of the conference. You'll notice that I put my email address and my phone number on here for you because, as I mentioned, this is a work in progress. This is me as a dietitian working with these GI patients and wonderful GI doctors trying to figure out what we should be looking for. And I'm always open to discussion and questions and thoughts, and I love hearing from you guys. So thank you.